episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome, everybody, once again to another episode of our show, bringing you another fascinating guest today who's helping to create a better tomorrow. Today, we have the honor of being joined by Gwen Darien, who is Executive Vice President for Patient Advocacy and Engagement at the National Patient Advocate Foundation, which is an organization that has a mission of bringing patient voices to health system delivery reform, helping to develop and drive initiatives to promote equitable access to affordable quality care, and prioritizing the patient voice ultimately in healthcare system delivery reform to achieve person-centered care. Gwen is also the executive vice president of their sister organization called the Patient Advocate Foundation, which is also a national nonprofit organization which provides case management services and financial aid to Americans with chronic, life-threatening, and debilitating illnesses. Gwen is a longtime patient advocate. She's played leadership roles in some of the country's preeminent nonprofit organizations. She is herself a 3-time cancer survivor and came into cancer advocacy with the express focus on changing the experiences and outcomes for patients who came after her, and ultimately to change the public dialogue all about cancer and other life-threatening illnesses. In 2005, she started the first standalone advocacy entity in a professional cancer research organization, which is at the American Association for Cancer Research, where she launched CR Magazine, a magazine with people with cancer and those who care for them. Later, she served as the executive director of the Sam Waxman Cancer Research Foundation, director of the Pathways Project, and executive vice president of programs and services at the cancer support community, where in each role she championed ultimately placing patients at the center of health system change, whether it was for research, public policy, or direct services, while serving as the chair or on the board of a wide range of programming committees and workshop faculties, including the Community Engagement and Genomics Working Group at the National Human Genome Research Institute, a member of the U.S. Pharmacopoeia Board of Directors, and the past chair of PCORI's Patient Engagement Advisory Panel. She continues to write about her experiences, and her most recent piece, which I encourage everyone to take a look at, Transformation, My Experience as a Patient and an Advocate, in 3 chapters, ultimately appeared in the National Academy of Medicine Perspectives recently, and we will have a link to that in the bio. But all that being said, Gwen Darien, welcome to our show today.
Thank you, Ira. You forgot about the shoes and the Persian food.
I was going to ask you about the Persian. Actually, I have Persian food in the list here, believe it or not. But I thought I'd say sometime. Well, welcome.
Thank you. It's such an honor to be here.
Yeah. It's great having you. And I really, I have to say, I went into your piece per National Academy of Medicine's perspective. Initially it was saying, okay, we're going to focus this show on a lot of your advocacy work, but really there's so much about Gwen Darien to talk about. In this piece, you take us on an amazing journey that you've been on from age 35, non-Hodgkin's lymphoma, 20 years later, breast cancer, 5 years later, endometrial cancer. You fought them all, you won, and along the way in this piece, you outlined ultimately how cancer has influenced who you become, and ultimately the different stages of being an advocate, evolving as an advocate. I'd like to spend a little time on the show today just going through sort of these 3 learning experiences with you and what each one taught you. And, if we can really start off 35 years ago, and this non-Hodgkin's lymphoma diagnosis, and sort of walk through what you learned in each stage. I think that'd be a great way to start things off, and we'll get into the organizations in a little while.
Yeah, that's absolutely. So actually, it wasn't 35 years ago. I was 35.
Yeah.
But when I was 35 years old, I was running a contemporary art center. I thought that I was going to spend my career in contemporary art. I started working in museums when I was in high school, and then went to Sarah Lawrence College and really focused on art and political science and French. And so I thought that was going to be my path in life. I had incredible experiences. I was able to do great work and work with people from all over the world. And then I started not feeling well, and I knew there was something seriously wrong. And one of the things that I learned from this experience, and my doctor diminished it. He was, there's nothing wrong with you. You're a healthy 35-year-old woman. It's all in your head. The kinds of things that would happen, particularly to young women at that time. And I knew something was wrong with me. So I pushed until I was diagnosed with cancer. And it was shocking. It was absolutely shocking. Nobody thinks at 35 years old, they're going to have a life-threatening disease. Nobody, you kind of move from the land of the well to the land of the sick, as Susan Sontag would talk about in her illness as metaphor. And I also learned through that experience, I learned so many things about that really helped me later on in my as a cancer survivor, and also in my life and in my work and in my family. I learned that I learned to be a little less judgmental. I learned that I could actually ask for what I wanted. I didn't always have to wait. And I also learned that I wanted to live my life and go through my life and do my work in a way that it was that there was, as the disability rights advocates started, their slogan was "Nothing about me without me." And my first diagnosis was everything about me without me. I just sort of followed. My dad is a retired internist, my doctor at the time. I just sort of followed them down the hall. And one of the images that I think is still the most evocative to me, and it's still kind of seared into my memory, is at the weekend I was diagnosed, going to my doctor's office, and he and my dad were ahead of me in this kind of long hall. In the doctor's office, they both had blue blazers and probably khaki pants on, and I was sort of following them. And they were deciding what kind of treatment was going to save my life. Now, I will not say that I'm not incredibly grateful for that, but nobody talked to me about anything. Nobody talked to me about fertility. Nobody talked to me about quality of life. Nobody talked to me about what I wanted. It was really very much focused on treating the disease and keeping me alive, which is fine. And it was fine at the time. And but there are long-term impacts of a cancer diagnosis, and for me, those impacts were the long-term impacts were two secondary, to a secondary and a third cancer, second and the third cancer. So after I got out of that, I decided to change my career. I left contemporary art and decided to go into patient advocacy, not exactly knowing what I was going to do. But I knew I wanted to do something different. And I also knew that I wanted things to be different for the people that came after me. And at that point, and I'm in a cohort of people, a lot of whom are women who are diagnosed as young adults and now are not young adults. And we all had bad diagnosis stories. We all had this kind of lack of physicians trusting us, or our healthcare providers trusting us. And we all were sort of compelled to go into advocacy at the same time in order to change that experience. So that was a little over 25 years ago, a little over 25 years ago now. And so many of my friends that I've been doing advocacy work with for the past 25 years have had late effects of cancer. Some secondary cancers, some other kinds of diseases, but we've all maintained this kind of passion for this work, and it's been different over the years, but we've maintained a lot of passion for this work. And I can't imagine doing anything more fulfilling than what I've been doing for 25 years. And it's been very, very varied. I've done, as you read off my resume, I've done so many different things. And I've always sort of held to that value of nothing about the patient and family without the patient and family in the center. And building bridges, and one of my former colleagues said my job was desilification. And that's what I've really focused on. And it's been, I will never, ever say that cancer is a gift. I don't like that. I really don't like that metaphor, that framing of cancer, but there were many things that brought a lot of meaning into my life from this experience. And so things can not be a gift, but also give great meaning. And that's sort of that's how I think of it over the past number of years. There are people I met I would have never met. There are things I got to do I would have never gotten to do. I got to integrate a lot of my experience in contemporary art into what I did in advocacy. I made incredible lasting friendships and relationships and continue to do so. And I think the other thing that was always very important to me is that I always had a focus on health equity and equitable access. And that meant that's evolved over the years. So it's meant very different things as we sort of evolved from a kind of looking at these issues to trying to dismantle bias and racism and their effect on people's health and communities' health. So, but that's always been a very, very strong focus for me.
And, as I was reading through your piece, and I just quote you a couple of times here, sort of after the first experience, you say, I can no longer simply be the passive recipient of decisions made about me without me, as we're just saying, no matter how well-intentioned and clinically sound they are. For the second time around, you say the passive young woman who previously sat by for the first diagnosis, trusting my doctor and father to decide the fate, that's gone, and you have a whole other group around you. You are not just an advocate for yourself, you're an advocate for your husband now, your children. The stakes are different. Third cancer, similar type piece, but you go into sort of, as you were mentioning, the secondary cancer story and so forth. And then, that you had some conclusions that I heard you also talk about in some previous presentations, your basket of advocacy for yourself and other things that you suggest. You mentioned, obviously, telling importance of stories, the importance of understanding you're not alone. There's many that have come before you and will come after you in this. And then also connections, the importance of these very important connections, not just family, but friends and so forth. Talk about some of this portfolio of learnings in terms of becoming an advocate.
So stories, as you said, have always had, and they've always been the center of the advocacy work that I've done, but stories that are not simply a person's story, but as a person's story as they relate to what other people are experiencing and the change that we want to see. So one of the things that, so the first thing I did as an advocate was I did 2 magazines for people with cancer. And the first one I did was launched in October 1997. And it was for women with breast and reproductive cancer. And that was really where, at that point, that's where a lot of the cancer advocacy was situated, was in the breast cancer community. And what we did was actually, which was kind of radical in this, is that we brought in reproductive cancer as well. And we focused very much on profiles of people, on their experience. It was very, very heavily driven by photography and by stories through visual stories as well as written stories. And I thought about it often in the same way that I thought about doing an exhibition when I was running a contemporary art center, which is that you kind of have a venue. You have an audience, you create a dialogue with that audience, and you do it in different ways. You respond to what the audience tells you they need, and you also interject what you know is going on in the community around you. And that's been a principle that I've worked with throughout the time that I've been doing advocacy. So one of the rules for the magazine was that every cover had to have a person making eye contact with the reader. Okay. And with the second magazine, there were two concept covers. And they actually featured me in the concept cover, but I said, you can only do it if you cut off my face. But those were the only 2 covers that didn't have eye contact. Everything had eye contact, and everybody could see themselves in these different stories, and they could relate to the stories. And they could also relate to this idea that there are many universal things that you go through, common things facing a life-threatening illness, but that doesn't diminish your individual experience. And so we were trying to kind of marry those things and open a dialogue between universal experience and individual perspectives and experience. So we profiled cancer survivors. In the second magazine, we profiled cancer survivors and also healthcare providers, those who took care of them. We photographed people. We brought people together. Actually, we did some incredibly wonderful photo shoots where we'd bring a group together and do a photo shoot, and everybody get to know each other, and we'd sit around and we'd make these connections, and then we'd do like a group photo shot. And there are two that really stand out for me from that point, from that time. One was a photograph. We did a lot of work on Black women with breast cancer, because the statistics, Black women still have a much higher mortality rate than white women, but they have often a lower incidence rate, and things have not changed in 25 plus years, 30 years, things have not changed. So we did we did a conference on African-American women and breast cancer. And I worked with my colleagues in the, who led cancer advocacy groups for African-American women. And we did it together, because you don't helicopter into a community, you work with people in the community. Sure. And you listen. And then we did a piece in the magazine, and we did a photo shoot, which is a little bit like the jazz photo shoot in Harlem, the jazz photograph in Harlem. And I can't believe I'm forgetting the photographer. But we had all these women get together, and we did a photograph on the steps of a brownstone in Harlem. And it was a really, really powerful piece. We also did we did a piece on Long Island, and kind of the high incidence of cancer in Long Island among many different women from many different backgrounds and ages and everything else, a very diverse group of women. And we set up a photo booth in a mall on Long Island, and had pictures taken of everyone one by one. And we had, I don't remember, 50 people on the cover. And then throughout we created this collage and then put it on the cover and put it in the story. So we told a lot of stories in different ways. And we told stories from the perspective of words. We told stories from pictures. We also started podcasting a little bit. I mean, very, very old, very nascent days of podcasting for the second magazine, which launched in 2004, I believe. So storytelling was always very much a part of it. And part of what we do now in our team is that we hold storytelling workshops. We help people learn how to tell their story for impact. We help people kind of prompt so that they get to the essence of their story. And I, of course, tell my story often. I'm very open about my story, but I'm also cognizant of the fact that there are things that I have become more comfortable sharing, but there are things that I wasn't comfortable sharing, even as a very open about my cancer experience, and encouraging others to be open about their cancer experience.
Let's talk a little bit about both organizations, the National Patient Advocate Foundation and the Patient Advocate Foundation, slightly different but sort of complementary missions. You have quite going through an elite board of directors and scientific advisory board. Talk a little about who Nancy Davenport Ennis and Jack Ennis are, the background of the organization, and a little bit about how they work together and what they do independently, of course.
Right. Well, and Nancy and Jack have retired from the organization. So the CEO has been Alan Balch for the past 7 years. Nancy, I actually have known Nancy for, since she founded the organization. We sort of started our advocacy work concurrently, but Nancy started the organization in order to help people navigate the primarily healthcare insurance system. And she did it based on the experience of people that she knew, and started from, a kitchen table, and then grew into this. It has grown in the past 7 years into a very large organization that helps helps nearly 200,000 people a year now. So it started from this kind of grassroots, what do patients need, what do people need, into how can we kind of simultaneously move to change the system while giving people the help they need now. So that's very much what we do at NPAF and PAF, is that PAF does the direct patient services, case management, copay relief, financial assistance, a lot of community engagement. We have evolved from, we used to say one patient at a time, but now we say one patient in one community. So a lot of community outreach. And NPAF takes what we learn from our patients and what we know is happening in the kind of healthcare ecosystem, and focuses on initiatives that help bridge that gap for primarily lower income patients who are from traditionally marginalized communities. And so all of our work focuses on that and how we can make change, but also how we can make sure that people don't fall through the cracks right now. And I think that's one of the things that really is a differentiator for our organization from lots of organizations. Well, first of all, we are pan-disease. We don't have a disease focus. Mm-hmm. We will help anybody in need, to the extent that we have the resources, that we have both human resources as case managers and any kind of financial resources or financial funds. And so it is, because we work with people with serious and chronic and debilitating illnesses, it tends to be things like cancer and cardiovascular disease and MS, and we've also worked with sickle cell and CF, cystic fibrosis. But we do these things kind of simultaneously, and we know that you can't help the individual unless you can change the system. And we also know that you can't change the system unless you understand what the needs of individuals, families, and communities are. So it's a really interesting kind of, I would call it a learning patient advocate organization, because we learn about things and we keep on developing them. So we have a few initiatives that we've been doing for years. The organization was founded on equitable access to affordable and quality care. And then we have a number of initiatives that we've been working on for a long time. So we've been doing a lot of work around costs of care, and in many different ways, whether it's conversation or whether it's helping people afford their care on an individual basis, whether it is talking about how people feel about talking about money, which is very personal, as opposed to the clinical cost, what true costs are for patients, because it's not just your clinical cost of care. I will say for myself, my first diagnosis, I paid off my medical debt relatively quickly, but I chose to do that, but the cost of daily living was incredibly high, and it took me more years to pay off that debt that I chose to put on my credit cards. So it was the total cost of care. It was the cost of parking when you're going to have radiation treatment every day. It was the cost of food that I wouldn't necessarily, I ate a lot more meat than I ever have during that time, because I needed that. I needed that for sustenance. It was, everything else that I needed to get myself back to wellness. My second cancer diagnosis, it was the diagnostic phase, because with breast cancer and some other cancers, screening is part of your well visit and is part of your, as part of your right under the Affordable Care Act. But diagnosis is incredibly expensive, because once you have a diagnosis, a diagnostic mammogram can be hundreds of dollars in copay, and a screening mammogram is $0. Same thing with colorectal cancer and colonoscopy. And then my third cancer, I was diagnosed in one plan year and treated in a second. So I've shared this before, even though I'm very well insured. I have a job I love that and am paid very fairly for that job. It still has taken me a few years to pay down that debt, because there is so much cost sharing for patients. And there's so many things that change. You're sort of penalized for being sick in many ways through our health insurance system and our healthcare system. So we've been focusing on that. We've also been focusing on trust and equity. But I will say trust, it was a matter of trust that brought me into advocacy, because my doctor didn't trust what happened to me, what I was telling him I was experiencing. So that's what we may not have characterized it as such when we were younger advocates and the group of us started doing advocacy, but that's really what it was. It was a matter of trust. So we've been working on that for a long time. There's so many aspects of our healthcare non-system, the system that's held together by duct tape, that haven't changed. And there are also so many things that haven't changed in terms of health equity and health inequity.
Yeah. Talking about the cost of care conversation initiative, and I think, I forget where it was, but I was reading another publication, and you're in this publication, and you were talking about, I don't know what which phase of your treatment it was, but it had to do with erythropoietin therapy, where you were saying, look, I gotta boost my red blood cells, and all that. It's much more expensive than the chemo was, and so forth. And I don't know how long ago that was, but here we are in this weird 2021 era where cancer drugs, I mean, $500,000, $1 million for some of these CAR T therapies and the stuff that's coming. What are some of the cost of care conversations you're having when you get into these really tough therapy? I say tough. Yes, they're groundbreaking and they're smart drugs and all this, but they still, they work on a small percentage of people, and they have these ridiculous costs associated with it. What are some of the conversations that you see at the organization when you have cases like these that come in front of you?
So I think it is a very difficult conversation, because there's a very difficult conversation to be had around risk and benefit, cost and benefit, and cost as a greater term than just cost of medical care or clinical care. And so it is a very fraught conversation, because many people want to do whatever it takes to get better. We've also had people who stopped treatment because they were bankrupting their family. And one of the things that we found in the patients that Patient Advocate Foundation serves is that that's one of their biggest fears, that people are going to die and leave their family in financial ruin. So it is a really difficult conversation to have. I think the only way to do it is to kind of take it from that lens about what is the cost, what is the benefit, what does it mean to you in your life, what does it mean to you, what do you decide? I don't want to make a decision for somebody about whether I can't make a decision for somebody else whether the cost of the medicine is worth it, but I can open up a dialogue with people to talk about what they care about and what their goals are and how that fits into how you are looking at cost. And it is there are incredibly expensive cancer therapies, but some of them do work. Or it's like Hep C, where the treatment worked. So in fact, it was hugely expensive, but then it was a one-time treatment, and cancer is not quite the same. So I try to open up a conversation around cost and benefit, and marry and integrate that with a conversation about patients' goals of their treatment. And I've seen it in different ways throughout the course of my path with cancer and my path in advocacy, about what I wanted and what was important to me at different points in time. So I think that's what you have to start with, is what is important to the patient, what's important to the patient vis-a-vis their family, vis-a-vis their quality of life, and really open up that discussion. And also think about the holistic cost of cancer, not just the cost of clinical care, but everything else. And so that's the only way, that's the way that I can think of having those conversations. I think it leaves room for a dialogue without without judging about the, how costly this is or what the goals are, or making any assumptions about the reasonableness or unreasonableness of people's expectation of treatment. I think you just focus on values. You focus on goals. You focus on families. You focus on communities, and people do very different things.
Another initiative of the group is the rural healthcare initiative, and if you're 250 miles from a doctor, you're not going to get to the doctor as much. But you also, were quoted in another, and I apologize, I didn't jot down where these quotes came from, but you were basically saying, look, during this last couple of years, we've sort of, many of us have become rural healthcare people. Personal fact here, I should have had my colonoscopy last year. I didn't, because I wasn't going into any doctor's office.
No, absolutely not. I feel the same way. Me too.
So sorry, Dr. Ziegler, I'll be in. But talk a little bit about this theme of sort of what we're seeing in terms of the non-communicable diseases, because we're not going to the doctors, because of the pandemic, and some of how this relates to what you do with the Rural Healthcare Initiative.
So what we focused on in our rural healthcare initiative was we focused on three very different regions and areas, and then we brought in a bunch of other areas in our documentary. So we did a documentary about a friend and colleague in the Mississippi Delta, Freddie White Johnson, who's at the University of Southern Mississippi working in cancer control, and founded the Fannie Lou Hamer Cancer Center. Mississippi, as we know, is not a Medicaid expansion state. So we also worked with her and other people in the community around cost of care conversations. And what Freddie really brought to life, what Ms. White Johnson really brought to life, was what it's like in a rural Black community that is facing hospital closures, that never had very good access to quality care, that was very much on the bottom of healthcare quality in this country, and was not a Medicaid expansion state. So what did that mean? And for her and her organization, and on both sort of the rural health and the situation of rural health, some things were like, you couldn't get to, what do you do if you're having a heart attack and the nearest emergency room is 3 hours away? What do you do if there are all these hospital closures? That's part of the reason. What do you do if you can't get in the doctor's door because you have to pay to get into the door? And what is that gatekeeping like? And how do you deal with the kind of intractable legacy of racism in the Mississippi Delta? So we focused on that a lot, and what it meant to her community, and the community where she was a leader and had this organization. I'll say one of the things that you and I have talked about a little bit, but also came up through in the documentary we did, is that a lot of what she and her organization has done is focus on the social determinants of health, making sure that people had food, making sure that people had transportation, making sure that people had housing or housing secure. I mean, that is a huge issue in poor rural populations, is what is people's living situation like? Do they have electricity? Do they have indoor, what happens when they go home? And then also what happens when people don't have food. She told this incredible story about going to visit this woman, and she was trying to shoot a blackbird so that she could have Thanksgiving dinner. And I mean, you hear this. And so, it's almost unimaginable, the way that, and so a lot of their focus has been bringing food to people. During the COVID epidemic, we're still in the pandemic, but in the height of it, a lot of the focus was helping people get access to COVID vaccines and access to care if they were impacted by COVID. We did another documentary with a nutritionist in Vermont, in a very rural area, in a relatively poor area, where he talked about not just telling people about nutrition, but actually having cooking classes and going into schools and going in as Mr. Carrot. You might have seen that, which was adorable, and teaching kids what to do with things. And one of the things that one of the kids, he put out fruit, and he would put out fruit with, things that they could dip it in that increase the nutritional value. And he put out a strawberry, and one of the kids had never seen a strawberry before. Mm. And then we did another piece with a friend and colleague at the Crow in the Crow Nation in Montana. And she talked about access to healthcare for her people and kind of trusted messengers for her people. So after losing a baby daughter to cancer, she decided to become an advocate, and she became the trusted messenger in her community to help women get to cancer screening and then cancer treatment. But then she also got to do things. She would drive them and buy them lunch. She would buy them lunch so that they had food. They ran a COVID. They did all these things during the COVID pandemic because of vaccine access. And then she also found a partner in Montana State University who she's been working with for almost 20 years to do research, community-based participatory research in the Crow Nation. So one of the takeaways, one of the things that is really important from this, first of all, the stories really illuminate what is happening. And so this just reinforces why stories are so important. But we also looked at the sustainability of these partnerships, and we have to design these kind of community partnerships, whether they're with rural communities or urban communities, for sustainability. We can't just go in and leave. And so that was one of the key points, and one of the key takeaway points was that we are designing these for sustainability with the people in the communities based on the needs that they have. And so we did documentaries, we did panels, we did a podcast series on rural health, and we tried to illuminate what it was like, what it was like in different parts of this country that were rural, and what were the healthcare access and barrier. What was the healthcare access like, and what were the barriers to healthcare? Mm-hmm. And one of the other reasons that we did this is that there seems to be an idea about what rural healthcare means and what a rural community is. So I grew up in Wisconsin. I grew up in Milwaukee, but I grew up in Wisconsin. So, farms in Wisconsin are sort of many people's idea of what rural is, which is kind of working class farmers who are predominantly white. And we often don't look at the other kinds of rural communities. So we tried to really focus on what were communities across the country, what were rural communities, and really put a face and a voice to those. And that relates back to what we did, when I was telling you about that photo shoot of women in Long Island. I mean, the whole point was to putting the faces and putting a face and a story to the women who are impacted by breast cancer, and also trying to trying to reframe. There was reframe what people thought about were women in Long Island, and show the diversity of women in Long Island, and show the diversity of rural communities in the United States.
And that, I'm glad you brought up the social determinants, because that's a topic that we have touched on a little bit on the show, and it's just so very important in terms of, as you were saying, the holistic component of what we're dealing with here, especially with these unmet medical needs. So I appreciate bringing that theme up. It's interesting. One of the in going through, putting aside the Persian food for a moment, in going through your extensive bio, in the late 1990s, early 2000s, you were the editor and publisher of a magazine called MAM for women with breast and reproductive cancers. And at the time, you were labeled a bit of a renegade by People magazine. You would publish on so-called taboo subjects, such as dating after mastectomy. I guess sort of, maybe that's not a topic that's taboo anymore. Maybe it is, but what are some of the current taboo subjects in 2021 that you may have to deal with, aside from obviously dealing with costs of care and access to care and social determinants and equitable care? What are some of the taboo subjects that may pop up during your work?
So it's a very interesting question, because I'm working on a number of projects that are trying to have more direct and open conversations about what was maybe previously taboo. So sexuality and cancer treatment is still a it's a huge issue, and it is something that people talk about behind closed doors and not out in the open as much as they should. I will say that no oncologist has ever asked me any questions about and I can barely say it. I mean, here I am. I've been an advocate for 25 plus years, and I could barely say sexuality, but it is one of the things that I'm very uncomfortable talking about. But we're working on a project that we're working on with that's funded by the Patient-Centered Outcomes Research, called Engaging Virtually in the Time of COVID. And we're looking at models for engagement to look at for generating research questions on women's health, specifically sexual and reproductive health, in breast cancer, in women, breast cancer patients and breast cancer survivors, compared to my colleague at University of Illinois Chicago, who is a woman living with CF and a historian of medicine, as to how they developed their model in the CF community, which has always been virtual because they can't be together in person because of the risk of cross infection. So it is really interesting that it is still a very difficult subject to bring up. And I published one of the first pieces, I think, that was really very direct about sexuality sexuality and cancer survivors in whenever that was, 2000. And I remember kind of women coming up to me and kind of whispering in my ear, "Thank you for doing that. I'm so pleased that you actually talked about it." And it still feels the same today. So when you're making treatment decisions, or you're deciding about what kind of surgery to have for breast cancer, that is not part of the conversation, and it should be part of the conversation. And then when we get into these, so what we do in this phase is we're convening meetings of breast cancer survivors and breast cancer patients to talk about these issues, to think about what we want researchers who are doing patient-centered research, outcomes research, to study. And it's incredible getting behind this kind of closed door of the breakout room, which is only open to women with breast cancer, and seeing what comes out, and seeing the emotions that come out, and seeing what I share. I surprise myself. I mean, it's not that I surprise myself, but sometimes I do, because I try to not script to what I'm thinking, what I'm going to say. I try, to think about some of the themes I want to talk about in various different things, whether it's a podcast, a panel, or anything else. But I also try to leave room for saying what I'm feeling at the moment. And this last session we had, there were a lot of tears, and it was we talked a lot about loss, and loss of not having to have, family, in not being able to have children after cancer treatment, going into early menopause after cancer treatment. And it was still it's really, really raw, because it remains a taboo subject, and it remains a subject that people are really uncomfortable talking about. And so for me, you've probably seen it because I've written about it. After my first diagnosis, I was just newly divorced. I had a short first marriage. And then in middle age, I found a man that I found my partner, and we got married, and he has, and my daughter's actually here right now. She's out having coffee, but she's visiting from Colorado. But I married him, but I also married a family. So my stepkids were, when we married, Isabel was 13, and Stephen had just turned 15. So I've known them more than half of their lives now, because I've known them for 15 years, but I was never able to have children, which was a huge loss. And people would say the most biological children, but I was able to have children in a very different way.
Yep.
And people would say the most insensitive things to me about children and not having children. And, they would make assumptions. I mean, it was, and there's still things that people say all the time that they don't think about the impact of what they're saying.
Yeah.
And they don't think about what the impact of people around you, and what is, what they're focusing on. I still remember when I had chemotherapy for non-Hodgkin's lymphoma, and I remember being at my dad's house in Wisconsin for Christmas, and my sister, one of my sisters has kids, the other doesn't, and my niece was like a year and a half at that point. Her brother wasn't even born, my sister's child, to whom I'm very close. And I remember walking her around the house because that's what she wanted to do. She was learning how to walk, so I had to hold her up. She held onto my fingers, and I had my hat on because I wore a hat rather than a wig, and like it would start to fall off as I was walking her around. And I remember that incredible love I felt for her, but also that incredible loss I felt for for what was going to happen for me in terms of bearing children. And so I am just, and so there's a very, and that's sort of woven through a lot of cancer survivors' lives, men and women, often more for women than men, but absolutely for men. But then I got this then I had this incredible opportunity to be a mother to two amazing young adults, and they were young kids then, and was able to find a path to having a family. But it is, so it is always going to be difficult, and those conversations are always difficult, and it is something that oncologists often are uncomfortable talking about.
Sure.
So I brought up in my first treatment, was this going to impact my fertility? I was also 35, so I was getting on the the older age of the ability to have kids. But and my doctor, I'm not sure if he actually did this, but I feel like he did it, that he patted me on the head and said, "Don't worry, dear, we're focusing on getting the cancer, about taking away the cancer and curing your cancer and not focusing on other things."
Mm-hmm.
And so that's the other reason I went into advocacy, was like being treated as my disease, not as a full person. So that's one of the taboo subjects. Then the other, I wouldn't say taboo subject, but I think one of the areas that we really have a kind of moment of reckoning and a moment of opportunity is to really squarely face what structural racism and social determinants of health what the impact is on the health of this country. And so it's not taboo, but I think part of what's happening now is that people are having conversations in public that they used to have behind closed doors. So I just co-chaired a meeting with one of my colleagues and friends, Reggie Tucker-Seeley, for the National Academies of Engineering and Medicine on promoting health equity and cancer care delivery. And I don't think we would have been able to do that workshop with the same kind of directness that we did 2 years ago. That we wouldn't have been able to do this workshop 2 years ago. One of the panelists said, I just have, he's a community partner in research. And he said, just tell the truth. We just have to tell the truth. We can't keep on, we have to face the root causes of inequities, of treatment of one community versus another, and what is considered deserving and undeserving. But we have to tell, and the only way we can start is by telling the truth. And then Alma McCormick, who I talked about earlier from the Co-Nation, she was on one of the panels that I moderated, and she talked about the historical trauma to her people in a much more open and direct way than I've heard before. And she also talked about forgiveness, but what she said was that it was forgiveness to liberate her people, not for the benefit of those who had inflicted the historical trauma. And so, and it wasn't that she wasn't, I mean, she was absolutely open to creating relationships and building bridges. But she also talked about very, very directly the historical trauma, the land, the erasure and the taking of land, the alcohol and substance abuse problems, the orphanages, in a way that you know, we've been working together for years, and I hadn't heard her speak in that way. And the same thing with so many other people during that workshop. And that workshop, actually, all of the sessions should be up next week from that workshop, all the videos. But so those kinds of things that are still taboo, but moving, they're taboo among certain groups, but they're moving more into the center. So I've seen both things staying behind closed doors, but also things coming out sort of front and center in a very direct light. And you know, this is one of the things I kind of like to think about is that we started off, well, first of all, we started off keeping everything in obscurity. Then we moved to shining a light on things. Okay. And now we've moved to the point where we're stepping into that light altogether, or the people. And I think that's really a huge change in the way that we're looking at society and we're looking at health.
Absolutely. Absolutely. And I really appreciate you sharing those stories. I mean, it really adds a lot of clarity to the scope of what you're involved in, and really, really impressive. Moving to a slightly lighter subject.
Yes.
This has been a wonderful conversation, and I really do appreciate everything you're talking about, Gwen, and listening to your journey. But on another front, you are located up there in New York City. I am down here about 90 miles away in Philadelphia. And if you took a journey down to me, in my little neighborhood here of Society Hill in Philadelphia, we could walk around, and I could take you to an Afghan restaurant. I could take you to a Yemeni restaurant. There's some good Ethiopian restaurants, a lot of the standards. But I went online and I Googled the closest Persian restaurant where I am right now. It's about 22 miles away.
Wow.
So
wow.
I'm going to access any Persian food if you come down here. Talk about your love for Persian cooking.
So my dad's Persian. I'm first generation Iranian American on my dad's side, and my mother's side. I have a very, very, let's just say my family represents many different American experiences. And I'm not sure if we're a melting pot or whether we're a tossed salad. And when we were taught history years ago, that's what they differentiated. Are you a salad or are you a melting pot? So my dad emigrated here when he was about 18 because he wanted to go to medical school. And he went to college here, and then he went to medical school. And he was inspired by the doctor, the local doctor. He grew up in and around Shiraz, Iran, who used to ride around on his red bicycle, helping people. And my dad wanted that life. He wanted to help people. And he didn't really want to drive around in a red bicycle. He probably wanted to drive around in a red sports car. But it was, you know, he wanted to be embedded in the community as a healthcare, as a doctor. And then my mother's family, my late grandfather was Morris Goldman, so Eastern European Jewish. And then my mother's mother was German Protestant. And they had been a farming family, and they'd been in Wisconsin since before Wisconsin was a state. My grandfather was first generation, and his mother barely spoke English, and my dad was first generation, so Muslim, Jewish, and Protestant.
Nice.
And so I would say the Jewish and the Muslim side are really into hospitality. The German Protestants, not quite as much. Although my grandmother was a wonderful host. But so I've never been able to go to Iran. My dad tried to take us a long time ago. He only went back once in his whole lifetime, but there's always been something, whether it's the Iranian government or whether it's our government that has kept it from being, I don't know, maybe safe to go. I started exploring that heritage through food, through film, through not so much through literature, very much through food and film. And I love cooking Persian food, and I love having people over, and I love making them way too much food. And coincidentally, my husband and I, when we met, we both had the same Persian cookbook. And the first solid food my daughter ate was a Persian stew, which is called a karesh. So when she was a couple of years old, before I knew her, that was her first solid food. So we have a little negotiation about how much rice I'm going to cook, because in Persian recipes, you do 1 cup of dry rice per person. In American recipes, it's more like a quarter to a third of a cup per rice per person, dry rice per person. But I love feeding people. I love sustaining people. My husband and I both cook a lot. It's difficult to find a good Persian restaurant. There's one great one in Brooklyn, but a lot of them are not as good, but it's just amazing food, and it's amazing cuisine that is both delicate and bold, and it's kind of sweet and salty and all sorts of things you think about, and full of incredibly healthy ingredients. And so when I was growing up, my dad, unlike most Midwesterners, my dad wanted us to have more of a Mediterranean diet. So, most of my friends would have huge pieces of meat for every meal. We had meat kind of as a side, like they do they talk about in real Mediterranean cooking. You had rice and you had vegetables and you had other things, but you had a quarter pound of meat as your portion, not a pound of meat as your portion.
Sure.
So that's where I kind of got it from, was how do I learn about my dad? And I learned about my dad a lot through food. And then I think the connection is, and the entertainment is all related to everything that I do. I mean, I have kind of I have a group of, I call them co-conspirators. Actually, one of my friends came up with that, but I have a group of people, some of whom I've been working with and collaborating with for 25 years, and some that I just started in the last 2 years. And I always tell people I never lose a phone number, because I'll work with anybody who is open to working with other people. And that's not everybody, but that's a lot of people. And you can create some incredible change with a group of people that are willing to work with you and be open and listen and collaborate. And so that's what I do in food, and that's what I do in advocacy.
Outstanding. Yeah, and if we could get the price of the saffron down at some point.
Oh, yeah.
Because a side story, because I've always had slightly elevated systolic blood pressure, and saffron's one of those things. They actually studied quite a bit in Iran. There's a lot of publications on how good it. And I was like, looking at the price, I can't take that. I just have to stay with the celery seed and things like. But I do take medicine for it. But I enjoy saffron when I.
If we don't have backup saffron in the house, it's a crisis.
Oh, that is a crisis.
It's a crisis. Yeah, we can have saffron crises.
Wow. Well, you're a fascinating person, Gwen, and this has been a fascinating story. Really illuminating everything that you've been through. What you've built, obviously on your own with the different publications, and now obviously this amazing role, the different boards you serve on, and just wishing you the best with all of this and all this important work that you continue to do. For everybody that is going to be listening to this particular episode of our show across the podcasts, or watching on the YouTube channel, you have been listening to Gwen Darien, Executive Vice President for Patient Advocacy and Engagement at the National Patient Advocate Foundation, also Executive Vice President of the Patient Advocate Foundation, their sister organization. We will have in the link Gwen's writings entitled Transformation, My Experience as a Patient and Advocate in 3 chapters, recently appearing in the National Academy of Medicine Perspectives. And I encourage everyone to read through that. And as I said, we will link to that as well. But Gwen, I want to thank you for taking the time out of your schedule to do this. Thanks for everything you are doing, have done throughout your career, and continue to do. And as we like to say on this show, thank you for creating a better tomorrow. It's such an inspiring story, and it was great listening to you.
Thank you so much. It was such a wonderful conversation, and you elicited stories for me that I hadn't thought about in a while, and that's what always makes. And so was so happy to be able to talk about the sort of range of experience and also what was going on in our socio-political climate. So it's personal, it's community, it's socio-political. So thank you so much. And thank you for giving me this opportunity. It's been a great honor for me as well.
It was great having you.